Good evening, colleagues and students from India, and good morning, good afternoon for all of them from the rest of the world. Today, we are having eACE 2022, that is the 5th Academy of Clinical Experts. This is an update in hematology, including hemato-oncology. This webinar is brought to you by Mumbai Hematology Group. It is supported by Novartis and managed by Perfect Square. I thank Mr. Rahul, Mr. Dinesh, and Lekha from Team Novartis, Yash, Kalpesh, and their team from Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speakers of day one, and these are Dr. Valeria Santini from Italy and Dr. Walid Ghanima from Norway. All our discussants were themselves eminent hematologists or medical oncologists, and you participants for sparing your valuable time on a Wednesday. Today is day one, the session one. We have lecture on MDS, role of sabatolimab in the treatment of high-risk MDS. Guest speaker is Dr. Valeria Santini. She is Associate Professor of Hematology, University of Florence, Department of Experimental and Clinical Medicine, MDS Unit Manager, SOD Hematology, AOU Careggi, Florence, Italy. This will be followed by a panel discussion, which will be moderated by Dr. Biju George, Professor, Department of Clinical Hematology, CMC Vellore. And these are our panelists and discussants today. Dr. Abhishek Dudatra, Ahmedabad, Dr. Ankit Rayani, Ahmedabad, Dr. Karuna Kumar, Sikandarabad, Dr. Mahadeva Swami, Goa, Dr. Narendra Agarwal from New Delhi, Dr. Rintu Sharma from Ludhiana, Dr. Sandeep Shah from Ahmedabad, and Brigadier Dr. Satyaranjan Das from Noida. So over to Dr. Valeria Santini for her lecture on role of sabatolimab in the treatment of high-risk MDS.
Thank you very much for this kind invitation. Thank you to all the colleagues, and thank you to Professor Agarwal that is so kind to invite me. It's really an honor to share with you some of the novel approach to the treatment of higher risk MDS. As you know, the therapeutical options for treatment of higher risk MDS have not been changing so much in the last few years. And the problem is that the first choice is based on the comorbidity and the general health condition of the patient that allows us to choose for an active treatment or supportive care, and on age lately to decide whether these patients have to be treated with transplant. I want to remind you that transplant is still the only option that brings to cure, and otherwise we have treatment that just prolongs survival, but that are bound to go to a second-line treatment. In fact, we are treating with hypomethylating agents as a standard therapy. We know many things about this treatment. We know that these are the drugs and the agents, azacitidine and decitabine, able to assure prolonged survival in higher risk MDS. But we know that we cannot interrupt this treatment because this interruption induces a loss of response. Some patients, like patients with higher risk and complex karyotype, in fact achieve response, but it's a very short-lasting response. And when patients do relapse, have a shorter survival. So we know that we have many advantages, but the disadvantages is that we can never stop treating, and we treat until progression. The effect, the positive effect, is somehow retarded, and there is no eradication of the neoplastic, myelodysplastic clone. So one important thing to keep in mind is that even if we achieve response duration with decitabine or azacitidine may last 6 to 26 months. And when we lose response, median overall survival is around 5 to 6 months. And these are real world studies that allows you to understand that when we treat with azacitidine, the median overall survival from the starting of treatment is 16 months. Now, which are the most important and recent preclinical findings that allows us to understand whether we can change our approach, the standard and traditional approach with hypomethylating agents we're using since almost 20 years? I marked here that somatic mutations are important, as well the role of inflammation, but I highlighted that immune dysregulation is a novel variable that we have to keep in mind to change our treatment approach. And then there are, of course, still to understand what the apoptotic and survival pathway contribute, how they contribute to MDS, and still the impact of DNA methylation dysregulation. We know that somatic mutations are present in more than 90% of MDS patients. And we have been studying mutations since already 10 years, knowing that the most important and frequent ones are SF3B1, TET2, and other splicing gene mutations. So these genes are not only important for the pathophysiology of MDS, but also because the number of these genetic lesion and pathogenetic lesion, I should say, impact on overall survival. So patients who have none or one mutation have the longer survival compared to patients who have more than 6 or 7 mutations who have the shorter survival. This is independent of any treatment until now, both for lower risk and higher risk MDS. But what is really interesting is that MDS mutation induce an activation of innate immune signaling. The presence of MDS driver mutation, like the ones present also in CHIP and ARCH, so in clonal hematopoiesis like TET2, DNMT3A, and SXL1, do activate immune signaling by stimulating the activation of the inflammasome. It's something that we see with aging, and similarly, we see the same phenomenon in MDS. We thought in the beginning that was proper of deletion 5q MDS, but we know now that as I mentioned, the CHIP mutation are the ones that are driving this inflammasome. And the innate immune signal respond to the inflammation. The ERAC4, TRAF6, NF-κB, and cytokine are activated, and the myelodysplastic cells experience pyroptosis. Now, the chronic inflammation typical of MDS is able to give a competitive advantage to hematopoietic stem cells and progenitor cells in MDS, so that there is a switch in signal transduction, a switch to non-canonical NF-κB signaling, and there is an activation in all the pre-leukemic MDS cells. Now, what can we do for this immune signaling? Can we interfere with it? We just said that NF-κB signaling, the activation of Wnt and beta-catenin signaling in parallel with cellular senescence is able to increase the secretion of pro-inflammatory cytokine, creating like this a genotoxic environment that favors hematopoietic stem cell of male dysplasia, but not the normal one, and giving rise to bone marrow failure picture. So again, in this picture, we do have clonal hematopoiesis. We have an increase of cells with bearing TET2 mutations and other mutation. And the presence of this mutation, clonal hematopoiesis, increase of other mutations, somatic mutation, may induce the progression of the disease and onset of acute myeloid leukemia. There are therapies that have been proposed recently to stop and block these inflammatory pathways. And cytokine inhibition has been proposed with inhibitors of interleukin-1 beta, or the alarmin inhibitors, or TGF-beta inhibitors like luspatercept in lower risk MDS. But another important approach may be the one that takes into account the role of immune checkpoints and therefore of immune checkpoint inhibition in MDS. In this picture, very simplified picture, you see that the myeloid dysplastic blast is in fact target of many immune cells. The T cells, first of all, but also macrophage and NK cells. Now, T cells do express TIM3, but let's see what happens in the context of, in the condition of MDS. There are many multiple co-inhibitory receptors that are in fact expressed on T cells, and T cells are exhausted in cancer. So the T cells that infiltrate solid tumors and other tumors are somehow exhausted, and they do express in increasing amount inhibitory receptors, among which also TIM3. So the co-expressed and co-regulated receptors may induce over-exhaustion of T cells. So they are expressed during exhaustion and they increase and maintain such exhaustion, blocking the activity, the anti-tumor activity of T cells. Now, TIM3 function as an inhibitory receptor of innate immune cells. It's present on T cells, as I mentioned, and induces the apoptosis of type 1 T helper cell. It's expressed on monocytes with decreased TLR response, but it's also expressed on macrophage and on NK cells that have a decreased cytotoxic activity and lower interferon gamma production when TIM3 is overexpressed. And dendritic cells also do express TIM3 with decreased cytokine production. So it's really an inhibitor receptor that has multiple functions. And in fact, as I mentioned before, the overexpression of TIM3 is proper of dysfunctional T cells. What does that mean? It means that there are T lymphocytes that overexpress TIM3. They are usually overexpressing also PD-1, and they are the T cells infiltrating solid tumor. These T cells do not function normally. They have a reduced cytokine production. And this phenomenon is observed also in hematopoietic neoplasia like AML. They do not produce interferon gamma, and they do not produce TNF alpha as normal T cells should do. At the same time, TIM3, as I alluded to, may be a loop contributing and increasing T cell exhaustion in neoplasia. So the stimulation of CD4 positive CD4 positive T cells and the continuous stimulation leads to T helper cell exhaustion. And the exhausted T cells overexpress largely TIM3. So not only they do not produce cytokine, but they also do not proliferate. So these cells are really not useful and not active against immune reaction against tumor. And another important observation has been made by blockage of TIM3. So if we use a TIM3 antibody, we see that the TIM3 cells are blocked, and there is an enhanced expression of granzyme B in CD8 positive T cell. And this is quite important because apparently the use of TIM3 in vitro use of TIM3 antibody enhances the activity of CD8 positive cells during chemotherapy. And there is an induction and modulation, I would say, of NF-κB in dendritic cells and in dendritic cell lines in vitro. And another important thing is that the treatment with TIM3 antibody promotes the Fc receptor signaling in mast cells and in macrophage. If we block TIM3 in a preclinical model in mice and also in vitro, we see that the anti-cancer activity is increased in mice. So it's a very important effect because it reactivates the immune reaction. TIM3 is not only expressed in cells of the immune system, but also in leukemic stem cells, in the majority of AML types, but also in MDS. TIM3 is expressed, TIM3 mRNA is expressed in acute myeloid leukemia blast, not in normal hematopoietic stem cell. Not only mRNA, but also the protein is increasingly expressed in AML and not expressed at a high level in normal bone marrow cells. So TIM3 is expressed on immune cells and in leukemic blast. And the TIM3 expression, and I would say overexpression, correlates with disease severity in myelodysplastic syndromes. So if we consider CD45 cells, so or the white blood cells in low-risk MDS and in high-risk MDS, as well as in secondary MDS, acute leukemia, secondary to MDS, you see that the expression of TIM3 protein is increasing with the number of blasts. And the same is true if we consider only CD34 cells. So the intensity of the expression of TIM3 increases with the severity of the disease, being the highest in acute leukemias, AML, post-MDS. Now, why is that, and what is the role of TIM3 expression in leukemic stem cells? Now, in the normal stem cells, there is a very low, if any, expression of TIM3 and galectin-9 production. But if there is a clone that outgrows, like it happens in MDS, you see that there is an increased expression of TIM3 and an increased production of galectin-9. Now, TIM3 binds to galectin-9 and increases self-renewal of the cells by inducing NF-κB and beta-catenin pathways. With the increase of the number of blasts and the progression of the disease, these cells overexpressing TIM3 and overproducing galectin-9 are increasing with the autocrine and auto-maintenance of the dysplastic clone. So TIM3 in this way supports the autocrine maintenance and autonomous growth of dysplastic blast. So in this way, you may understand that if we target with an anti-TIM3 antibody like sabatolimab, both the immune cells and the leukemic cells, we should obtain very important results in the attempt to eliminate the dysplastic clone. So you see that in this way with sabatolimab, we may stop the autocrine loop that maintains leukemic stem cells. And at the same time, we promote the innate immune response, we promote phagocytosis by macrophage, and we therefore should have a deeper, a more pronounced anti-leukemic effect. So gene mutations are important. These gene mutations are the ones who stimulate the inflammasome, they stimulate innate immune signaling, but the innate immune signaling may be dysregulated in MDS. TIM3 is an immune myeloid regulator. It targets both immune cells and the leukemic stem cells. So we think that blocking this receptor and this protein and these pathways activated in MDS may be indeed promising to block both the self-renewal of neoplastic cells and to promote phagocytic killing and T-cell activity. Now, this, let's say, immune shift that comes from solid tumor has been attempted in MDS and in hematological neoplasia in general. So, as you may know, there have been several attempts to use traditional checkpoint inhibitors blocking PD-1 and PD-L1, like nivolumab and pembrolizumab, or CTL4, like ipilimumab. All these attempts have been really successful in terms of activity. So overall response rate has been increased, even if it must be said that the safety of this drug has been very poor in MDS patients. And therefore, there has not been a great success of this approach. As all the therapies in MDS, these checkpoint inhibitors have been coupled and combined with azacitidine in higher risk MDS. But as a matter of fact, there has not been a great development of this immune approach, mainly because of the safety concern, but also because of the scarce durability of the response observed. So there are new therapies in development that take into account the immune dysregulation in MDS. And these novel immune-based pathways that are targeted are the CD47 pathway. CD47 is a do not eat me antigen that is present on leukemic cells and abolish macrophage phagocytosis, and is targeted by antibodies like magrolimab and others. IRAK4 is also activated, as I showed previously, in MDS, and then a specific inhibitor is under evaluation. And I already introduced the concept of blocking TIM3 overexpression by sabatolimab. In fact, once again, the rationale for targeting TIM3 is quite strong. It allows both immune target and leukemic target. And it's a high affinity monoclonal antibody that is quite specific for TIM3 that also increase the phagocytosis. So let's see what are the clinical data. Sabatolimab, as all the approaches in higher risk MDS, as I mentioned, has been coupled with the hypomethylating agent azacitidine and azacitidine. This is the phase 1b study that was directed to enroll very high risk and high risk myelodysplastic syndrome patients, as well as acute myeloid leukemia. The patients would receive decitabine, a standard dose IV of 20 milligrams square meter per 5 days, per day for 5 days, or azacitidine for 7 days, a standard dose of 75 milligrams square meter per day. There were 2 schemes and 2 schedules for sabatolimab, either day 8 and day 22 for 250 milligrams, or once every 4 weeks, 800 milligrams. The primary endpoint of the study was the maximum tolerated dose, of course, the safety and tolerability, and the secondary endpoint, the preliminary efficacy, response rate, and duration of response. The patients included in this study with the 2 arms were pretty old. I'm highlighting here only the myelodysplasia patients that were 53 patients with a median age of 70. The majority of patients, as you see, stopped treatment, and the reason for discontinuation in 1/4 of the cases was the undergoing stem cell transplant. For other patients, there was indeed a disease progression that induced to stop treatment. This patient had a median age of 70, and as you see, performance status was mainly 1. The risk category was in the majority of cases high risk, IPSSR. And among these, 15 patients had the presence of TP53 mutation, where 33 patients had at least one or more than one adverse risk mutation according ELN. Now, the tolerability of sabatolimab in combination with azacitidine or decitabine was quite good. Patient with MDS experienced only the adverse events that we are used to see and observe in patients treated with hypomethylating agents, that is, myelosuppressive event like thrombocytopenia, anemia, febrile neutropenia, but also the GI events that are typical of hypomethylating agents. None of the experienced adverse events were severe, that is higher than grade 3, and no serious, very late adverse events were observed. But to go a little bit more into detail, what I was scared of when I start treatment with an antibody were the immune adverse event. And in fact, the only 13% of the MDS patients who received sabatolimab experienced a possible IM adverse event. But I must say that all the ones observed in MDS were of low grade, 1, 2, and were transient. If you see here, I compared to AML patients treated in the same study who experienced a little bit more grade 3 adverse event. Sabatolimab and hypomethylating agents demonstrated a very good and durable clinical response in patients with very high and high-risk MDS. The overall response rate was 56.9%, with the marrow CR in 11% of the patient, but a marrow CR and a complete remission in a very high proportion of cases. The marrow CR duration was around 8 months, whether the duration of complete response was around 19 months. So the estimated 1-year progression-free survival, we will come back to this, was 54%. The median duration of response, 17 months. Among the patients with very high risk or high risk MDS, some, as I mentioned, had expressed and carried severe prognostic marker like TP53 mutation or the adverse risk mutation like SXL1 and others. But you see here that the overall response rate in TP53 mutated MDS was really good, 71%, and more than 65% for patients who had adverse risk mutation. And if you compare with AML, once again, you see that the results are quite encouraging. The median duration of response in this subpopulation was even better than in the global population, more than 21 months for TP53 mutated and 16 months in the patient with adverse risk mutation. Some of the patients who received sabatolimab and hypomethylating agents could undergo transplant after following this kind of therapy, and there were no adverse events different from what expected. The overall survival after transplant was extremely good. 12 patients underwent transplant after receiving sabatolimab and azacitidine, and 7 after sabatolimab and decitabine. So the post-transplant outcome was in general good. median follow-up was pretty long, almost 2 years, and the overall survival at 2 years was 69%. Now, in this moment, there are several studies ongoing or just ended of sabatolimab in high-risk MDS. We have the Stimulus MDS-1, when the final analysis has just been carried out. I will come back to this, comparing sabatolimab IV with decitabine and decitabine or azacitidine versus placebo. Then we have the Stimulus MDS-2 that is ongoing, high-risk MDS, and this time also chronic myelomonocytic leukemia with bone marrow blast, CMML2. And then just started Stimulus MDS-3 for high-risk and very high-risk MDS as a triplet, sabatolimab plus azacitidine plus venetoclax. And there are other studies going on only in the US. Now, May 4th, we received these results of the final progression-free survival analysis of the Stimulus MD1 study. This phase 2 study, unfortunately, did not meet the statistical threshold for complete remission and progression-free survival. So, in some way, failed the objective, but it is very important to go on with treatment of these patients, because maybe we will have results for the overall survival and additional data for the safety of sabatolimab. So the program I just showed you with sabatolimab and hypomethylating agent, doublet or triplet, and a phase 3 study that the MDS-2 just completed enrollment and is still going on. So we will have more results to discuss and more study to evaluate. So the one study that I just showed you, the MDS-2 that just completed enrollment, is comparing the sabatolimab to placebo and azacitidine standard dose. And we will have hopefully soon the result of this study. Now, as a matter of fact, we can say that we have a novel avenue that we can put in practice in MDS. So the combination of immune active drug and hypomethylating agents may really set a new path for MDS. There are more biological information that we need to obtain for improving this approach, but the immune stimulation may indeed prolong survival and contribute to eliminate this plastic clone. So we will see in the future new studies with an immune-based treatment. Adverse events with sabatolimab seem to be really transient and of low grade. So I think, and we are quite confident that we may continue with these combinations. Because what will be the future would be to treat with the base and the backbone of hypomethylating agents plus any investigational therapy, would be a triplet, and many of the studies now include venetoclax as one of the 3 drugs. Or is it possible that in the future we can even avoid the use of hypomethylating agents and find a doublet of new investigational therapies, especially if including immune regulating drugs? I think we have a lot to expect from future. I wish to thank you, and I'm really happy to answer any question. Thank you.
Thank you so much, Dr. Valeria, for exposing us to these new developments occurring in the field of MDS. And I'm sure something would happen and there will be breaks in future. So may I request our colleagues over here to ask questions to her? Start with Dr. Biju.
Yeah, that's a fantastic lecture, Dr. Santini. I had 2 questions. One was, when we look at immune dysregulation in MDS, earlier dictum was that it is more in lower risk MDS rather than in high risk MDS. So is there any data where this drug has been used in lower risk MDS?
That's a very good question. Thank you. So it's true. When we look at the inflammasome and the immune and pro-inflammatory cytokine, we see it much more dysregulated in lower risk MDS. But sabatolimab apparently has a different regulation, meaning that it reactivates, sabatolimab blocking TIM3 overexpressing cells reactivates the T cells. Reactivating T cells and macrophages, we may hope to eliminate the leukemic cells, the dysplastic cells. I have in my knowledge, I have no news about the use of sabatolimab in lower risk MDS, but I know there have been a preclinical data and possibly some studies will be going, but not as far as I know. Very good point.
I had one more question, sir. In terms of infections in this group of patients, are there any unusual infections? And two, is there, say, immune-mediated lung problems that occur?
No, the immune-mediated side effects as lung problems were very, very rare, extremely rare, and there were no increased rate of infection other than what expected with hypomethylating agents therapy. So there were, of course, febrile neutropenia cases and so on and so forth, but as much as we see with the hypomethylating agents alone.
Thank you.
Thank you, Dr. Biju. Others have any questions? And I ask the audience also to put their question in the question box if they have. And the colleagues over here, if they have any question, maybe on any aspect of MDS, not necessarily this drug. Okay, very new subject. Many are not exposed to this talk so far. So, Dr. Valeria Santini, I'm extremely grateful to you for sparing your time and making us knowledgeable about the developments that are taking place in the management of MDS.
Thank you. For me, it's always an honor. Thank you.
Thank you. We're going to move to the panel discussion now. I'll just share my screen to introduce the panel discussion, which is on the same subject, the role of sabatolimab in the treatment of high-risk MDS. And as stated in the beginning, but for those who have joined in late, this will be moderated by Dr. Biju George, Professor, Department of Clinical Hematology, CMC Vellore. Our panelists, we told you who they are. Dr. Abhishek Dudatra from HCG Cancer Center, Ahmedabad. Dr. Ankit Rayani from Cure Hematology Oncology Clinic, Ahmedabad. Dr. Karuna Kumar from Yashoda Hospital, Sikandarabad. Dr. Mahadev Swami from Manipal Hospital, Goa. Dr. Narendra Agrawal from Rajiv Gandhi Cancer Institute, New Delhi. Dr. Intu Sharma from Dayanand Medical College and Hospital, Ludhiana. Dr. Sandeep Shah from Vedanta Institute and GCRI, Ahmedabad. Brigadier Dr. Satyaranjan Das from JP Hospital, Noida. So with that, I hand over the reins to Dr. Biju George.
Thank you, sir. I will just share my screen. Is the screen visible?
It was visible.
Now?
Yeah.
Okay. So this is the first time I've actually do a panel discussion on a drug which we've never heard before or used before. So I think it's something which is new, but I think it's a question of just getting some insights. And I would like to start by thanking Dr. Santini for that lovely talk that she gave on this topic. So I will start with this case scenario. This is a 62-year-old male who was evaluated for fever and transfusion-dependent anemia, found to have a pancytopenia, a hemoglobin of 5.6, a white cell count of 1,800 with 4% blasts, and a platelet count of 22,000. Bone marrow showed an MDS RAEB2 with 16% blast and trilineage dysplasia. Cytogenetics was a complex karyotype, and the IPSS-R score was 9.5, category of very high risk. So the first question would be, in an Indian context, what would be the kind of treatment that you would offer this patient? He's a 62-year-old. So the first three people who are there, Dr. Abhishek, Dr. Das, and Dr. Karuna.
Hi, sir. Dr. Abhishek here.
Abhishek, start.
Yeah, thank you, sir. So our patient is 62-year-old male and has a very high-risk MDS. So if fitness permits, he should undergo allogenic transplant. But before that, I would like to give some debulking agents. And out of these options, I think azacitidine plus venetoclax will be the first choice if finances are not an issue.
So Dr. Das and Dr. Karuna, are there any differences that you
Yes, sir.
would do?
Before, we need to know any comorbidities, what is his fitness, performance status and all. So if he's fit.
He is
And,
fit with no
yeah.
comorbidities.
Then as Abhishek said, we'll start azacitidine or hypomethylating agent. I would little bit think about venetoclax here. I would start with azacitidine. Then based on the response, I may add venetoclax later. So initially, I would like to start with azacitidine here. And then I'll take up him for allogenic stem cell transplant.
So since you said it this way, Karuna, let me ask you a question. So if you give azacitidine, how many cycles would you give before you assess response and say, I need to add on venetoclax?
So at least azacitidine 3 cycles we should give before
you assess.
Yeah.
Okay. Dr. Das?
I think I will also go in the similar way. Maybe it's only one HMA and followed by assessment after 3 to 4 cycles. And if he requires, then add venetoclax. If he's responding well, then look for a transplant option.
Okay. Dr. Santini, I would like to bring you into this discussion also. So in Italy, what would be your approach? A 62-year-old fit who's got MDS RAEB2, what would you do?
So this is a very young patient for my standard. So I would immediately test for HLA for donors in the family. And of course, I will give a hypomethylating agent. As I would say the number of blasts in the bone marrow was 16, if I
16.
remember correctly.
Yeah.
So I would go for in between 4 and 6 cycles of azacitidine alone. I wouldn't add venetoclax unless there is a clinical trial, because venetoclax has not been approved for MDS, and we still don't know the final results of the study that is ongoing of azacitidine plus venetoclax. So it's an interesting approach. It's probably going to be successful. This patient is young, no comorbidity, so it could be a very good idea. But as a matter of fact, I cannot use it unless I use it for off-label. And as soon as possible, as quickly as possible, I would transplant, because this patient is a complex karyotype carrier. So he will definitely respond for a very short time.
It's very interesting. You call this patient young and the rest of us called him old.
Yes. For us,
ma'am, I have a question, ma'am. Do you consider 7+3 at all in this case?
Sorry, I beg your pardon?
No, in this patient, will you consider 7+3 at all?
No, not at all. Not at all. Because it's a complex karyotype, and it's not going to respond. We know it for the experience of many years. So it could respond for 1 week or a couple of days, but it's not really, and it's very toxic anyway. So
I agree. These are the two.
I have a question. Sorry,
yeah.
Dr. J. Do you have any preference for azacitidine or decitabine?
In Europe, we are unfortunately able to use only azacitidine, but I do have a long-standing experience with decitabine that is a little bit more myelotoxic, but is also active.
Thank you.
So we actually gave the first cycle with azacitidine alone, because at that time, actually, the patient said that he did not have much, he was getting his finances ready for venetoclax. So after the end of the first cycle, we decided to give a second cycle of azacitidine with venetoclax. Now, so he's received total of 2 cycles. And so I would ask this question to Dr. Ankit, Dr. Sandeep, and Dr. Madheswamy. When would you do the assessment? Or would you do it immediately? Would you do at least 2 cycles of azaven only after 4 cycles? Or do you wait for complete recovery of blood counts, or any other thoughts? Start with you, Dr. Sandeep.
Yeah, if I use azacitidine alone, then I do assessment after 4 cycles. But if we use azaven combination, then even after finishing the first cycle, we do the reassessment on day 28 or day 29. I do the marrow and see whether patient has responded or not. And if patient is for transplant, then definitely after first cycle. If patient is not for transplant, then we may give 2 cycles and then reassessment. But if patient is for transplant, definitely after first cycle of azaven.
Ankit?
Yeah, sir, can we have the blood counts and what happened after
So
2 cycles?
so the counts had come up to about 2,400. Platelets were sitting at about 30,000-40,000. Hemoglobin had come up to about 8, but not requiring transfusions.
Okay, and the blasts have disappeared, or still
Peripheral blood, no blast.
No blast. So I would go for assessment after 1 cycle of venetoclax. That is the completed cycle. So immediate reassessment. And if the marrow is in remission and the cytopenia is not recovered, you can give a 15 days of gap before starting the next cycle. That way cytopenia can recover and the patient has less chance of infections, opportunity infections, but immediate assessment.
So Dr. Mahadev?
Sir, I do agree with the same thing what Ankit wished to do. Considering not much old patient, but still an elderly, but approach should be sort of aggressive. So I would wish to do immediately.
Okay. So Dr. Santini, let me ask you a question. You said you would wait for about 4 cycles before you assess. Is that correct?
Yes, I agree with the colleagues. So if you give only hypomethylating agents 4 cycles, at least, if not 6. But if you are using the combination with venetoclax, of course, you have to assess earlier. And as soon as the blasts are gone, I would just go for transplant.
Okay. So this patient, so we had given him 1 more cycle of azaven. And after that, we did a repeat marrow, which showed that he still had about 18 to 20% blasts in the bone marrow. On a flow cytometry, roughly about 24% blasts. So what would you like to do now? So Dr. Rintu and Dr. Narendra, 62-year-old. So would you now consider a 7+3 induction? Would you consider palliation? Would you consider taking a patient straight up for transplant if a suitable donor is available? Would you put him on to some clinical trial or any other options that you would consider?
Hi,
Dr. Rintu?
Hi, good evening, sir. Good evening, everyone. So I would just like to know, he was complex karyotype, right?
Yeah.
Was there TP53 mutation in that or deletion 17p? Was there any deletion 17p in his complex karyotype?
He had a deletion 17p in the complex.
Okay. So as we know, the patients with a deletion 17p complex respond better with decitabine compared to azacitidine. If that is an option, then we can give him decitabine, but definitely he should be considered for a transplant and we should search for a suitable donor as soon as possible. Considering his blasts have increased from 16% to 24% and he is having complex karyotype, he is less likely to benefit from a 7+3 induction. We can consider, if the financial constraints are there, then we can go for palliation. Or according to me, we can switch the hypomethylating agent, although I doubt how much benefit is going to be there. But we can switch his hypomethylating agent from azacitidine to decitabine since he is having deletion 17p.
What about Narendra? Is he online? Okay, Dr. Santini, over to you. So we've done 2 cycles, one with azacitidine and one with azacitidine plus venetoclax. And at the end of it, still setting almost same amount of blasts, maybe slight progression. What would you do in this scenario? Would you just continue and wait?
Yes, I would not be, well, I would be very worried, I would say, but I would go on because only 2 cycles may be not enough to obtain a response. I would be ready anyway to transplant as soon as possible, as soon as we see that the blasts are less than 10%.
Okay. Here we had a patient who did not have a matched sibling donor, did not have a matched unrelated donor. So the only option was a haploidentical transplant using the son as a donor. So if at the end of 4 cycles, continue to have persistent disease, then would we consider him for treatment with, like, for example, a combination with the TIM3 inhibitor? Or would we put him on some clinical trial? Or would you take up the patient for transplant? Dr. Santini.
To me, sorry. I thought it was to the other panelist. That's a very bad situation, actually. There are no clinical trials at present that can enroll patients who relapsed or were refractory to first-line therapy. So this patient never responded and cannot be included in any clinical trial. And there are no data at present indicating whether sabatolimab addition is active in this situation. We have been developing, we are actually writing a protocol for relapsed patients with sabatolimab and hypometilating agents to rescue these patients. But there are no data of the activity of the anti-TIM3 antibody in relapse.
Okay, so let me ask you one more question, and this is what Dr. Rintu had asked. Changing the hypomethylating agents, is there much benefit in that? So if you were using azacitidine, changing over to decitabine, will that help?
No, I did it several times, and I keep on doing when I have no choice and I have a patients like this, but there are no evidence that is really changing. What Dr. Rinu was saying is really correct, that there are evidence indicating that decitabine is more active on TP53 mutated patients. Nevertheless, there are very weak observation, very weak data and very weak demonstration that switching may improve the situation.
Okay. So I think we're just looking a little bit at the whole question of sabatolimab. So,
sir, I have a question, sir.
Yeah.
This patient, how long did he get venetoclax, sir? Is it like continuous daily basis, or is it like once 1 week or 2 weeks?
We gave it for 2 weeks.
2 weeks in a month.
Yeah. So problem what occurred was that when we were giving it, by the time we finished 2 weeks, the counts would drop very, very low. We had counts which dropped up to 300, 400, would get admitted with febrile neutropenia. And so we could not push it much longer.
So what happened, sir? Finally, have you taken him for transplant, or?
So he's just getting worked up. He's going for a transplant.
What is your opinion? The blast percentage of, let's say, 15%.
Yeah, so
what are the outcomes here?
So we have to be clear that anybody with sitting with more than 10% blast, we know that the risk of relapse is high. But here, I think we have no access to any of the other drugs. So I would consider going ahead with transplant, trying to get the disease burden down, and then considering putting him on some azacitidine maintenance post-transplant and see whether that will help him getting into remission. I mean, we are thinking of a combination of azacitidine with low-dose DLI post-transplant to try and achieve reasonable remission.
Can we give cytarabine and venetoclax combination to such patients? Because in few of patients, when azacitidine has not worked, we have seen response with cytarabine with venetoclax.
We have used it before, but not in a 62-year-old. So that is where I would be a bit worried. That is something, but we have to run. One of the challenges that I always face is sometimes the marrow is not very healthy, and so the cytopenia just drags on and on. So you have to, at some point of time, make a quick call in taking them up for a transplant. So here I would probably consider going for a transplant.
Biju sir, I wanted to ask, why don't we go for 1 or 2 more cycles with azacitidine and venetoclax, whatever venetoclax he tolerates, then get the blast percentage maybe less than 10%, then look for a transplant. What is your opinion on that?
So we generally would go up to 4 cycles, but at the end of 4 cycles, if you find that the blast percentage is actually remaining same or increasing, I am not sure pushing it further is going to help. Beyond 4 cycles, I don't think it will help too much.
Absolutely.
You have to change something.
This patient has just received 2 cycles of azacitidine
So
and 1 venetoclax.
We went on to 4.
Okay.
So last one question. So is there any role of 2 + 5 here? Something lesser than induction, 7 + 3?
I am not too sure whether chemotherapy will induce a reasonable remission without causing too much of infections. I mean, we have to remember in India, bacterial infections and fungal infections are quite a big problem. And you might end up making a patient who is reasonably fit and eligible for a transplant ineligible. And if that happens, that's worse. So I would not definitely consider. I agree that this is not the ideal scenario to do a transplant, but I think this is probably our best option. So Dr. Das and Dr. Karuna, your opinions on the role of TIM3 receptors.
As you told that I also don't have any experience. I am first time actually reading about this particular molecule. So really I can't give much, but yes, this is an unmet need of such kind of a patient who is not responding to a hypomethylating agent alone. Maybe an addition of another agent which is less toxic and well tolerable, that will help in taking the patient to kind of a remission and then gives us a time to do the transplant. I think that role it should play, and it will be a great. I think Dr. Santini has given a nice data, whatever towards the end. It may not be statistically significant, but if we can get some patients into kind of remission and do transplant, that will give us a very good result.
So Dr. Santini, can I ask you a question? Would there be any role of, say, adding, making a combination of this TIM3 inhibitor with another checkpoint inhibitor like nivolumab?
Yes, that's a very good point. In fact, the cells that do overexpress TIM3 very frequently do overexpress PD1 and PD1 ligand. So it is already ongoing, but I don't have the data. A study that is combining the checkpoint inhibitor and the TIM3. So I think that that's something that we will see in the future, because in this way we attack the cell from 2 sides. I think it's very important to see whether it works more.
And I think it's very interesting. I mean, I agree with you, Dr. Das. I'm seeing this for the first time, so I was also reading up to understand a little bit about TIM3. So it's very interesting that this interaction of TIM3 with what is called as galactic-9 actually causes self-renewal of these cells. And so a leukemic cell keeps on renewing itself and causing the cancer. And when you actually block it, that's the time when that synapse actually breaks off, and then there is phagocytosis of these cells. So Dr. Sandeep, I know we have to predict because we have never used it. So in a patient like that, like I mentioned, 4 cycles as a when, if you had access to the drug, would you consider using it? And do you think what kind of percentages are likely to benefit?
Indeed, I would use it because your patient didn't have any other choice, so any investigational drug is welcome. And as I mentioned to you, this is the objective of the protocol I just finished to write, and I will hopefully put in place soon. So adding sabatolimab in the patient who lost response to hypomethylating agents.
So Dr. Sandeep, let me ask you.
I will use the upfront triplet. If everything is available or clinical trial is available, then in such high risk patient, I think upfront triplet will be more useful. And usually we don't get the second chance. So that will be the first choice.
So Dr. Abhishek, so this was what was the data that was presented. Roughly about 20% achieve CR, 23.5% marrow CR, and some PR. Are you happy with these rates?
Yes, sir. So I think these rates are definitely better when you compare with the single agent azacitidine, because PR rates were very low, I guess, with single agent HMS. So we are seeing more PR rates. Even the durability is, I guess, better when patient achieves CR. And because only comparison is with single agent HMS.
So Dr. Ankit, what about its role when you have a TP53 mutation?
So TP53 mutation carries a less than normal average prognosis for patients with MDS and AML, especially AML. The same paper, same oral presentation, Dr. Brunner had also in a subgroup mentioned about TP53 mutation in patients with MDS and AML. So around, I think, overall response rate with TP53 mutation was around 60%, and there was around 20% CR rate, though the duration of response was not as one desired. There is definitely a role of sabatolimab in patients who have detected with TP53 mutation or 17p deletion along with MDS or AML.
So Dr. Santini, let me ask you a question. MDS with TP53 mutation, are there any other major drugs which have shown a reasonable response like this? I think there's the APR 286, which has also shown response in TP53. But are there any other drugs? This seems to be quite a dramatic response in this group of patients where it's very, very poor prognosis.
Yes. Okay, APR 246 that you mentioned was giving a very good CR, but as you know, the phase 2 studies were carried in the US and in Europe were very positive, but the phase 3 didn't meet the objective, so was a failure. Now, we have very good data with magrolimab, the anti-CD47 antibody that is now under evaluation. There has been a hold on this study because of the adverse events, but it seems to be extremely active on TP53 mutated MDS because it acts outside the cell, so it's increasing the phagocytosis. So it seems to be a way to bypass the bad prognostic impact of TP53. And again, you have seen the data I showed you about sabatolimab is the same principle. If you stimulate immune system, it doesn't really matter whether you express TP53 or not. Okay. So the data were very promising. We have to see what happens in the next studies with more patients and more TP53 mutated ones.
So Dr. Rintu and Dr. Narendra, your comments on the adverse events that were seen?
So as we know that sabatolimab, it basically acts by immune modulation. So apart from neutropenias, we can see the typical side effects which are seen with the checkpoint inhibitors, like autoimmune phenomena like arthritis, autoimmune hepatitis, then dermatitis. These are the few common side effects which can be seen with which we can expect to see with sabatolimab.
Dr. Narendra, any comments? Okay, Dr. Sanchini, so, I mean, usually we rarely get any drug which has got less side effects the way this has been. So when you've used it, is it truly a drug which has got hardly any side effects?
It's true. I was very worried, as I mentioned, when I started studying, having patient with sabatolimab, was terrified of the immune-mediated adverse events. So I was very careful. I kept the patients under strict control and everything. I must say that I didn't see any of the side effects that are mentioned here. The patients tolerated it extremely well. And as you see, the MDS patients had very low grade when they had any adverse event. And you see, I didn't see any neuropathy, I didn't see dermatitis, but again, we have to see the big numbers when the rate is so small.
Sure. So yeah.
Sir, just I wanted to ask to Dr. Santini, was there any increased cytopenias, what we expect from the HMAs in addition of sabatolimab? Was there any increased cytopenias? Like I was just going through, there is increased thrombocytopenia has been mentioned with this drug.
Yeah, no, there was nothing that I did not expect different from the patients I treated with hypomethylating agents. So, you know, it is difficult to say, but I actually saw what I expected to see with azacitidine. So, of course, in some patients, thrombocytopenia, neutropenia, but not really more or unexpectedly more than with hypomethylating agents alone. I was quite surprised.
Okay, I just pulled this out from clinical trials. So there are studies ongoing on sabatolimab with magrolimab, and of course the triple combination. So hopefully in the future we may see better results, and it could very well become one of the drugs that comes into this armamentarium of treating high-risk MDS. With this, we come to the end of this panel discussion. Thank you all so much for taking part. Thank you, Dr. Sanchini, for giving in your valuable inputs into this panel discussion, and over to you, sir.
Thank you. It was a real pleasure. Thank you. Very good discussion.
Thank you, Dr. Biju, for conducting that panel discussion so beautifully. Dr. Valeria for her contribution, and all our panelists for acting very, very effectively in this. We still have a minute or two if there is any question from anybody to Dr. Biju or to Dr. Valeria. We have 1 or 2 minutes.
So, Dr. Sanchini, let me ask you one more question. It is with regard to CMML, so chronic myelomonocytic leukemia. Is there any, I mean, some articles suggest that decitabine may be a better drug rather than azacitidine when we're treating. Is that clear data to indicate that, or there's no, I mean, any HMA is fine?
We have been conducting a randomized trial, the Dakota trial, in high-risk CMML, high-risk proliferative CMML. And we did see more response when we treated with decitabine, but comparing it with Hydrea, but we did not see an increased survival. So the patients who were treated with decitabine experienced more infection or related event and early death, but no, much more responses, but no increase in overall survival. So it was very disappointing. Now, comparing azacitidine with decitabine, usually if you have a patient who has blast but no proliferation, I would use azacitidine. So in practice, if you can do the IPSSR and the blood and the white blood cells are less than 12,000, I would use azacitidine. If it's very proliferative, I still think that if the patient is young, it's better to use decitabine.
Okay, thank you.
Okay, so thanks to all of you, and we move on to session 2 of the day. I'll just share my screen to introduce this session to you. So session 2 is a lecture on eltrambopac advances in evidence-based use of this drug in management of ITP. Our guest speaker this evening is Dr. Wahid Ghanima, MD, PhD, Adjunct Professor, Department of Hematology, Institute of Clinical Medicine, Oslo, Norway. And this will be followed by a panel discussion to be moderated by Professor Chandrakala. She is from Department of Clinical Hematology, KM Hospital, Parel, Mumbai. And our discussants this evening are Dr. Ganju from Nagpur, Dr. Baheti from Pune, Dr. Mahajan from New Delhi, Dr. Meshram from Mumbai, Dr. Das from Guwahati, Dr. Kalashetty from Bangalore, Dr. Gupta from New Delhi, Dr. Nemani from Miraj, and Dr. Sanyal from Mumbai. So first we'll have the lecture from Dr. Wahid Ghanima, and over to him.
Unmute. Good evening or afternoon. Well, it's evening in India. So you can hear me?
Yes.
Okay, and you see my screen and the presentation?
Perfectly.
Okay. Yeah, thank you very much for this invitation. It's always a pleasure. I've been giving talks to my Indian colleague the last 2 months, at least 3 or 4 I've given, and this, as I mentioned, it's always a pleasure. Well, the topic of, well, first, before I started, just showing you the map of Norway, and we are in this is the photo of our hospital, which is located in the county of Østfold, that is around 1 hour, 100 kilometers southeast of Oslo. The topic of my presentation is advances in the evidence of in the evidence-based use of eltrombopag in the management of ITP. And well, we have a 15 years evidence of, just 1 second, I will just remove this. Okay. Yeah, 15 years of evidence on safety and efficacy of eltrombopag. I'm not going to go through the 15 years of evidence, but these are the main studies that was the base, made the base for the approval and the licensing of eltrombopag in ITP. The RAISE study was the main one, and it's a 6-month studies, 6-month study where patients in ITP were randomized to eltrombopag or a placebo. And as you can see, the blue line represents the platelet response in eltrombopag treated patient versus the orange ones. The orange line is the placebo response, and the odds ratio was 8 times. I mean, 8.2, that's 8 times higher, greater odds of platelet response in 6 months. And the patient relapsed after discontinue. The platelet count went down after discontinuation of eltrombopag. The effect maintained and was evident both in splenectomized and non-splenectomized patients. You can see the blue lines, the stippled and the continuous line. These were the splenectomized and the continuous. In the continuous is the splenectomized, and the stippled one is the non-splenectomized. And you can see the same in the placebo. How about bleeding, which is obviously a very important endpoint? Well, we can see that this was much less bleeding, or less bleeding, at least significantly less bleeding in the eltrombopag treated patients, the blue line, as compared to the orange line. Well, patients from all these studies, the RAISE, the REPEAT, the 6-week studies, they went over into a long-term open label studies. About 300, a little bit over 300 patients enter this study, and the longest follow-up was about 8 years. And we can see at the endpoint 61%, the red one, which I marked in red, 61% of the patients achieved response in absence of rescue medication in more than 50% of on-treatment assessments. So of all platelet count, more than 50% of assessment were over 50 in 60% of the patients. That's what we say durable responses are about 60%, but we see responses up to 90% if we're looking for one platelet count over 30 or over 50. Okay, from here we go to some meta-analysis. One meta-analysis by Wang that was published in 2016 included all eltrombopag and romiplastim studies in kids and in adult. And as you can see, this there was a risk ratio of 2.7% of getting response, platelet response, that's platelet response in general in the TPO treated compared to the placebo or the standard of care treated patient. Durable responses, not all studies looked at durable responses, but those studies that looked at durable platelet response, as it was defined by the study, 7 times higher was the risk ratio. So obviously TPO are very effective. We all know that. When it comes to bleeding, all bleeding in general, the same thing. And reminding you, these are eltrombopag and romiplastim studies, but I always like to show meta-analysis. So reduced bleeding effect in general, and more importantly, it reduced severe bleeding to 50%. So, and even the effect on bleeding was more evident in eltrombopag study than in romiplastim studies. Okay, how about rescue medication? Another important endpoint, 50% reduction in the thrombopoietin, and other concomitant medication, the same, was a reduction in the concomitant use of concomitant medications. So the meta-analysis leaves no doubt that these treatments are very effective. How about quality of life? Well, of all the agents available in ITP, we almost only have quality of life assessment in eltrombopag and in romiplastim studies. Once again, the effect on quality of life is more consistent and evident in eltrombopag studies. And this is one of the, it is the RACE study, which is once again that using SF36, and you can see the purple or the violet bars, which represent eltrombopag. In that, there was a positive effect or a higher effect on in eltrombopag treated patient in all the domains. You can see that almost all the domains were went in a positive direction in eltrombopag treated patient. In many of these domains, and 6 of them, if not 6 of them or dimensions, the difference was significant, and also in the summary components, as you can see, that both the physical component and the mental component. This was based on the this is 4 different or 3 different quality of life and fatigue questionnaires or tools that were used in the extend study, which is, as I mentioned, the long-term study. And you can see all of them improved after inclusion in the study. And most of the effects we can see between 3 and 1 year, but the effect consistent. So it's a reduction of fatigue. There is improvement of quality of life. Now, how about adverse events? In general, the rate of adverse events were lower in, or were identical, actually, as you can see here in the meta-analysis, in the thrombopoietin versus, and almost all studies had the same effect. The adverse event rates were similar in the 2 arms. But when it comes to severe adverse event or serious adverse event, was actually a lower rate of the lower risk ratio in favor of the TPO arms compared to standard of care. So actually less severe adverse event associated with the thrombopoietic agent compared to standard of care. One of the specifically about L-Thrombopag, one of the specific adverse event is a transaminitis or elevation in liver transaminases, which occur in around 10% of the patient, mostly asymptomatic, and rarely results in discontinuation, but or permanent discontinuation of the L-Thrombopag. It can be handled very easily, either by reducing the dose or interrupting the dose temporarily. Most of the elevation in liver enzyme, it comes during the first year. So that's what makes it important to monitor liver enzyme at least once a month in L-Thrombopag treated patients. Okay, what about bone marrow fibrosis? Bone marrow fibrosis was actually, we're very much afraid and aware of this complication or possible potential side effect to start with. But several studies, and these are two on L-Thrombopag study, L-Thrombopag, it showed actually there's not that big increase in the rate of bone marrow fibrosis. In these two studies, on the one to the left, they used this is the extend material, and the one to the right, which I like more, this was specifically designed to look at bone marrow fibrosis. So all patients, they had biopsies pre-treatment, and then biopsies 1 year, and then biopsies 2 years later. And what we can see here, and they use the European classification for bone marrow, for grading of bone marrow fibrosis, that's from grade 0 to grade 3. 0, no fibrosis, 1, 2, and 3 is the most serious, with a collagen fibrosis. And we can see here that before pre-treatment, most of the patients were grade 0, and this was about 6% grade 1, which is up. You can even see grade 1 in normal healthy individuals. After 1 year, there was an increase in grade 1, and this is most of the studies actually showed that a number of patients, in the number of patients, around 1/3, there's an increase in a slight increase in bone marrow fibrosis. But we got a few patients with a grade 2 and 3, and by continuing a treatment, or they didn't see progressive fibrosis. But some of these patients with high grade of fibrosis, they discontinued. They were discontinued thrombopoietic agent. In general, if I want to summarize all the data, there are like 4 studies on myelofibrosis. A slight increase is seen often after initiation. Very few patients, around 10%, get even a moderate increase around MF2. And these patients, nobody now recommends to perform routine bone marrow biopsy unless there is an indication like loss of response, or you find an abnormal cells in the bone in the peripheral blood indicating fibrosis, then or fall in hemoglobin or so. Then we shouldn't perform a bone marrow biopsy. But if you perform a bone marrow biopsy and you find an increase like MF2, do a control biopsy. If you find MF3, discontinue. And usually the fibrosis is reversible in TPO-treated patients. Okay, how about thromboembolism? Well, we've all heard of thromboembolism, and I'm sure all of us who treat ITP patients with thrombopoietic agent have experienced one or another, either venous or arterial thrombosis. So we believe that it is a risk, it is a side effect. This meta-analysis was even more recent than previous one. It was published last year and included all studies, including the avatrombopag study, that is the this one. In the randomized control trial, there was no increase. This was slightly, you can see the diamond is in favor of the control group. But there was no significant difference. And in general, the incidence of arterial and venous thrombosis in patients with on TPO was 2.4%. But looking at the long-term studies, the extent study and the study on the long-term follow-up of romiplastim, we find 6% of the patient developed arterial venous thrombosis during 100 weeks. Both of them treated for 2 years, and they developed, we got the same 6%, 6 to 7, and there were 24 events here. 10 VTEs giving annual incidence rate of about 2.7 per 100 patients here. So if you treat 100 patients for 1 year, you'll get around 3 thromboses. So I think that's slightly higher than what we expect to see in the population, or it's higher. And we know that that ITP in itself is a thrombogenic disease, but giving the patient thrombopoietic agent, it doubles the risk at least for thrombosis. What are the implications? Well, the implications, if you have a high-risk patient for thrombosis, then you might want to consider another treatment, like an elderly patient with many risk factor of venous or arterial thrombosis or so, then, or antiphospholipid antibodies, not antiphospholipid per se, but probably antiphospholipid syndrome if not on or triple positive antiphospholipid antibodies or previous unprovoked thrombosis, then probably I would not want to use TPO the first line, but rather use rituximab or fostamatinib is available, and then TPO. But once you get thrombosis on TPO, I recommend, at least for venous thrombosis and for myocardial infarction, to continue on TPO and anticoagulate or give antiplatelets. The issue is with the stroke, slightly different, but it's important to give antiplatelet and anticoagulation before you stop, and then before you stop medication, because that is the treatment for the condition, and then you can reevaluate after 6 or 8 weeks. So this was the current, this was the evidence. How about the current place according to the guidelines? We have 2 main guidelines. The international consensus guidelines would put TPO among all the 3 thrombopoietic agents, actually among the subsequent treatment. So that's not the initial treatment, but the subsequent medical therapies with robust evidence. And that is based on the magnitude of randomized control trial and long-term trial. There are no other medication that have as good evidence in ITP that have so much evidence as eltrombopag and romiplastim. And you have a whole bunch of other immune modulating therapies that are less robust evidence because they have not been evaluated in randomized trial. How about the ASH guidelines? Well, the ASH guidelines make comparison between TPO together, splenectomy and rituximab, and based on the synthesis of the data, they concluded, the ASH and all the 3 conclusions, when you compare TPO to rituximab, there are suggestions. That's to say, there are weak recommendations because there's, as you know, no head-to-head studies comparing these medications. They suggest TPO rather than rituximab because of the higher durability of response with a thrombopoietic agent. Then it's around 60% durable platelet count elevation at 6 months compared to probably 40% or 45% with rituximab. But if the patient prefer to have if the patient prefers to avoid long-term treatment, then we might consider rituximab. So shared decision making is important here. If we are comparing rituximab to splenectomy, then rituximab first and then splenectomy. And if you are comparing TPO to splenectomy, they suggested they were equally effective, and that's right, both they are equally effective, the two therapies. But during the first year, they recommended against or suggested not performing splenectomy during the first year because of the high remission rates. Well, we have 3 thrombolytic agents, at least in many parts of the world now, and I think in India, both eltrombopag and romiplostim are available. In general, the pros of thrombolytic agents are well documented efficacy and safety, platelet response around 60 to 90%, treatment-free responses, as I'm going to show you, are 10 to 30%. When these medications were first introduced, we thought they had to be continued treatment to have effect, but now we understand and we have learned that we can discontinue actually in up to 30% of the patient without losing treatment. They reduce well-documented effect on bleeding reduction, well-tolerated, and rapid response. Within 1 to 2 weeks, we get the response. How about the cons of these therapies? They're maintenance therapy. They have so in the majority of patients, we have to continue a treatment, whereas dietary restrictions, particularly with eltrombopag, might be a little bit annoying to patients. Romiplostim is injectable. Hepatotoxicity, as I mentioned, with eltrombopag, and the long-term side effect of thromboembolism and bone marrow fibrosis. In general, the ASH guidelines and the international consensus recommends very much patient education and shared decision-making. When it comes to which medication we should choose, we should inform the patients about the cons and the pros and cons of all, and reach together with the patient a decision regarding which treatment they prefer, depending on what are their values and preferences. If there's high durability, if they important for them to have high durability and they won't mind having continuous therapy, daily tablets, then thrombopoietin agonists are the answer. If the patient accepts lower durability but wants limited administration, then rituximab is the answer. If the patient wants high durability and one-time treatment, then splenectomy, and won't mind surgical therapy, then splenectomy is the answer. Regardless, it's a decision that we have to reach with the patient together once again. Okay, what does the label says? Because usually we cannot use a medication if it is not licensed or approved by this. So the label is important. Now, the label in Europe is treatment of children, kids, and adults with ITP lasting more than 6 months. Whereas in the United States, it is the label is persistent or chronic. That's to say after 3 months for eltrombopag. I'm not sure what is the label in India, but we can discuss that later. I assume that it is 6 months too. You start with 50 milligram, you wait for a couple of weeks. If the platelet counts, we try to maintain a platelet count somewhere, well, here it's shown 50 to 150, but actually 50 to 100 is excellent platelet count to reach. And if the platelet count is lower than 50 after 2-3 weeks, then increase the dose by 25 milligram. If the platelet count is 150 to 250, then you might increase with 25 milligram. And if it's over 250, you might want to discontinue, but don't make changes often in just based on one blood test. Weight and the platelet count will fluctuate. So data restrictions are very important, as I'm sure you're all aware of, and Eltrombopag should be taken 2 hours before and 4 hours after ingesting products, dairy products, calcium-rich foods like cheese, and antacids, and some mineral supplements like iron, calcium, magnesium, aluminum, and so. Should we continue indefinitely if we are using Eltrombopag? As I mentioned, to start with, if we would have answered this question 10 years ago, I would have said yes. Nowadays, we know it is not correct. Many retrospective studies show that you can discontinue treatment without losing effect in up to 30% of the patient. This is a prospective study was done by the Italian group by Lucchini et al. And was published last year. And they treated 55 patients with persistent or chronic ITP that is with Eltrombopag. And if they responded at week 24, and that's the response rate was 34 out of the 51 actually responded. So around 60, almost 70% responded at week 24. If they responded with the doubling of platelet count or platelet count over 30 plus doubling, then they entered a dose tapering period of 8 weeks. So reducing by 25 milligram every other week until discontinuation. And of the 34, actually 17 patients remained in response. Out of these, 7 had complete response. And as we can see here, it was around 25% in general managed to maintain or met the primary endpoint, which is sustained response of treatment 6 months after discontinuation of rituximab, of Eltrombopag. So 1/4 of the patient had maintained a platelet count over 30 6 months after discontinuation. And those, as you can see here, and those who achieved higher platelet count over 100, they had, during treatment, they had higher response rates or higher probability of achieving response. Another study is the TAPER study, which we're going to present the results at EHA, and I can promise you they're very interesting result, because these were newly diagnosed patients, and they have just failed one course of or a short time treatment with steroids, and if they did that, they were eligible for a treatment with Eltrombopag, and if they achieved the platelet count over 100, then we started tapering, and the as I mentioned, the results will be presented, and they are looks very nice and confirm what we used to know. Okay. Do we have any predictors of response? Unfortunately not. This was a panel actually, which were asked what do they think about the predictors of, and what does predict remission. And actually younger age. Of all these, I would say platelet over 100 is it looks like it is associated with better remission rate or response of treatment. So what should we do if the patient does not respond to L-Trombopag? Well, what we can do, we have a couple of studies showing that patients who do not respond to Romiplastim or to L-Trombopag, they have like a 50% chance of responding to the other agent if we switch. So it's a routine practice now. If the patient failed to respond or loses response, or because of any other like platelet fluctuation or side effects, switch to other agent if you have it available, and you will have a 50% chance of getting response. And on the other one, everything's from 50 to 80. You can see here 80% here and 50% here if you're switching from Romi to L-Trombopag, around 50 in this study. And this is the opposite, around 80. But there is another study showing higher probability of achieving response if you switch from Romi to L-Trombopag. If you are not satisfied with the response, you should first maximize the dose. Frequent question, without maximizing the dose, these are non-responders. Maximize the dose, then ensure compliance is important, and add a small dose of steroids. This addition will often potentiate the effect of L-Trombopag or Romiplastim. And you can finally switch to another medication if the patient does not respond. If the patient initially responds but loses response, which is we experience it and find it in some patients without knowing why actually, you should first ensure compliance. Ask the patient whether they started on new medication, in particular calcium supplementation, very frequent in Scandinavia, and interact with L-Trombopag. So I have to be sure that the patient has not started on any calcium. Consider bone marrow biopsy, add small dose of corticosteroid, and finally switch if you are not managing to do to elevate platelet count. Finally, I would like to show you some studies showing promising results if you use L-Trombopag as upfront treatment. This is a very small study, and back in 2014, where they treated this upfront with single dose of dexamethasone, 40 milligram, and L-Trombopag for 1 month. And there were 12 adults, and these patients, the relapse-free survival, as you can see it, was over 66% at 1 year. So these are promising studies in a way. This was the first one. The second one was a 12-week treatment with L-Trombopag and also 1 dose of dexamethasone, and the endpoint was at a durable response of therapy at 6 months. So 12-week, once again, upfront treatment, dex plus L-Trombopag, also single arm study, endpoint 6 months. And you can see here 50 patients, 56% achieved primary endpoint. 2 of the 26 relapsed during the follow-up, but 24 remained up to 3 years in response. So this is a rate of 50 to 60%, far higher than what we achieved with Dex alone or with the steroids alone. So this is a quite promising approach. We still don't know why, but it is, I mean, why TPO induces remissions, but we know that they have many immunomodulatory effects. At present, this study is ongoing in Germany, and it's a randomization between L-Trombopag plus 1 dex and 3 dex. And this is will be for the primary endpoints, proportion of patients achieving sustained response of treatment at 1 year. And this study, I think, it's very interesting and will be a game changer if we find that TPO really induces higher remission rate compared to dexamethasone. Once again, I didn't touch on this, but prolonged exposure to steroids should be avoided. More than 2 months should be avoided. Thrombolytic agents are preferred second-line therapy, and eltrombopag provides higher durable response rate, reduces bleeding, and use of rescue medication. Eltrombopag improves quality of life and has well-documented safety and profiles. And there is a promising also data indicating that we can continue, we can discontinue eltrombopag in around 1/3 of the patient without losing response. So what we usually do, if the patient achieving a good response at about 6 months, I start tapering the dose and reducing it gradually until discontinuation. And thank you very much. I'll leave you with some, sorry that I wrote it in Arabic, this one, but that's a thank. And these are some pictures from Norway, the North Cape, the midnight sun, and the fjords, which we have a lot of them. And I hope you enjoyed the presentation. I changed the Arabic thing and yesterday, but I most probably I forgot to save it, or that's obviously I forgot to save the change.
Thank you so much, Dr. Walid, for that wonderful presentation. So we have some colleagues who may like to ask their difficulties to you. One question I have: if you develop a thrombotic complication on TPO-RA, is it a contraindication to continue or restart?
No, it's not a contraindication. Once you start, I mean, we have 3 different scenarios. We have the venous thrombosis. I continue without thinking of it. I just continue with TPO and start anticoagulation. The most important thing that we have a safe platelet level that we can anticoagulate the patient. The other patient category is the arterial thrombosis, cardiac thrombosis, or the myocardial and coronary artery disease, and that is I also continue thrombolytic agent and add the antiplatelet therapy. The third category, which I mean, all this, I mean, not evidence based, but this is what we do. I find it difficult to continue a thrombolytic agent if I have a patient on stroke, particularly large stroke, but don't rush and discontinue immediately. The most important thing, you give platelet, antiplatelet, or anticoagulation if the cause is atrial fibrillation, and then change therapy when you have stabilized the patient, if you want to. But there's no like evidence-based recommendations saying that this should not be done.
Thank you. Dr. Karuna, your question. Unmute.
Yep. Yes, sir. So I have a question. See, Trombopag is really a very good drug, which is coming as a rescue for most of our patients. Most of them feel better and very less side effects. Most of them tolerate well. There are some set of patients who don't respond to Trombopag. Suppose say we use at least for 2 to 3 months, then say probably this drug is not working. And we go up to maximum dose of 75 mg usually. So is there a chance in such few patients, can we go up further from 75 to 100 mg and still try for one more?
Well, I have to be honest with you and say, yes, I have tried it. It's not according to the label, but I've tried it. Yes, it's gone up to 100 milligrams, sometimes works, sometimes doesn't work. But if, yeah, you can do it. But then you follow up the liver enzymes once again, and you try to do something else later. But
yeah. Thank you. So one more question, sir. So how often have you seen elevated bilirubin with Trombopags?
bilirubin, I haven't seen bilirubin actually. It's 2-3% or something like that. It's very rare, but elevated in general, you get an elevation. You see it in up to 10% slight moderate elevation.
Okay. So one more last question, sir. So sometimes, we may need one more drug to maintain platelet count other than L-Thrombopag. So what is your comment on combining it with Mycofit or Azuran? Should we avoid these combinations? Or
yeah, I mean, it's first. Okay, once again, there's no evidence, but we do it all the time. First thing I do, I combine with steroid, but I don't want to maintain a patient on a higher dose of 5 milligram of steroids, because then we are just treating with steroids probably. But some, they really work, it seems to be a synergistic effect. So 2.5 to 5 milligram, that's fine for some time. If not, MMF. I have right now 3 patients on MMF and TPO or other immunosuppressants. This combination seems to be works good. The issue is that what you do after like 6 months of response or 1 year, and so try to reduce slightly TPO and see if the patient can continue on MMF alone or other immunosuppressant. So I don't leave the patient indefinitely on a combination. And if the platelet counts falls, then you quickly increase the dose once again.
Yep. Okay, thank you, sir.
Dr. Amita.
Thank you, Dr. Ganima, for a wonderful talk. I just have a couple of questions. Do you think avatrombopag has the potential in the time to come? Will that be our preferred drug? Because there are no, dietary restrictions. The time to response is shorter. And will it actually be positioned as frontline therapy? Because the time to response is, 70 to 96 hours. The second question was that L-Thrombopag has the potential to, work as a wonderful iron chelator. And why really hasn't more research gone into that? Because, as hematologists, it would really be a good adjunct to other chelators that we already have.
Yeah, for the first question, well, I have around 20 patients now on avatrombopag, and it's easier to use it. That's undiscussable. I mean, this is disputable. You don't need to worry about the interactions. You don't need to worry about the dietary restrictions. You don't need to worry about the liver enzymes. So all this, but it's not a magical drug. The time to response, I find it in a way very comparable to the others. Although the study is showing 60% of the patients within 1 week had a platelet elevation. But reminding you, these are 34 patients or 33 patients in the avatrombopag study. And then what we do, if the patient do not respond, loses response to L-Thrombopag or romiplostim, I switch to avatrombopag. And we have patients that respond upfront to AVA, and we have patients who do not respond upfront to AVA. So I don't think AVA is a magical, but AVA is an easier to use drug. Why haven't been studies? I don't think it's more the intracellular chelation of iron. It's not the type of iron chelators that we want to have when the patient is have an excess of iron and we want to remove it.
Thank you.
Dr. Marika.
But just one question: do you have AVA available in India?
No, not yet. Not yet.
Not yet.
But especially for children, because the dietary restriction is I'm a pediatric hematologist, so the dietary restriction for children is a huge concern for us.
Yeah, absolutely.
Dr. Walid, you said only the milk products should not be given. You showed a lot of things which can be given.
Yeah, a lot of things can be given. It's the dairy product that are a problem, and yes. I don't know how problematic, but that's
other
tell the patient
can be given. It is not necessarily long fasting as such.
No, that was to start with. Actually, the label was long fasting. You're right, and but they changed that. So now it's just a dairy product. Dairy product.
That has made it very easy now.
Yes, yes.
Mallikarjun.
Yes, sir. So good evening. Very nice talk indeed. So how do you define L-trombag failure and your thoughts on switching? And is there any data at all in really refractory patients of using more than one TPO agonist? Thank you.
Oh yes, there are definitely patients who are refractory to all three and even combination of TPOs. So yes, there are. These are the difficult patients. There's actually no definition rather than if the platelet count is not move any and not increase on treatment with TPO. So that would say that the patient is not responding. Sometimes you get a slight increase. I have a patient that sure its platelet count goes from 10 to 25, 30, and that's all what we managed to get her platelet count, and satisfied. Been for years on romiplastim. Very happy with that. The patient is happy and we're happy. And every time I discontinue, for a reason or another, platelet counts fall back to 10.
So yes, Dr. Anil, the next question was your thoughts on rebound thrombocytopenia. So whenever you use this TPO agonist for a transient duration, for example, to facilitate a surgery, so when some of the instances when you stop it, the count actually goes lower than the baseline. So your thoughts on rebound thrombocytopenia?
Yes, I think that was exaggerated to start with. We don't see it that often, but I've seen it in some patients. And if you follow exactly up the platelet count, you see there's a drop. I have a case that I always show. The patient discontinues because she didn't have more L-trombopag, and her baseline was around 20. She went to below 10 after that, but this wasn't a serious one. Yes, and another thing that you can experience it when you have the overshooting. You start with the dose, and then you get a very high platelet count, and you get confused and react immediately by discontinuing the dose or the stopping TPO, and then what happens? You might get a rebound, but not in all patients.
Thank you. Thank you.
So that's the last question we have. So thank you very much, Dr. Walid, for educating us. Great talk, wonderful question answer session. We'll begin with a panel discussion. I'll just introduce the panel discussion. So same subject, we are going to have the panel discussion to be moderated by Professor Chandrakala, Professor, Department of Clinical Hematology, St. GS Medical College, KM Hospital, Parel, Mumbai. And then our panelists, we have Dr. Ganju from American Oncology Institute, Nagpur, Dr. Abhijit Baheti from Dinanath Mangeshikar Hospital, Pune, Dr. Amita Mahajan from Indraprastha Apollo Hospital, New Delhi, Lieutenant Colonel Dr. Ashok Meshram from Aswini Hospital, Mumbai, Dr. Damodar, I don't think he has joined, Dr. Mallikarjun from Manipal Hospital, Bangalore, Dr. Nitin Gupta from Gangaram Hospital, New Delhi, Sandeep hasn't joined, Subha Prakash hasn't joined. So that's it. Let's begin with it. Over to Dr. Chandrakala.
Do you want me to stay or leave?
Yeah, please, if you can. Please stay, sir, if you can. Yes.
Sir, can you see my slides, sir?
Yes.
Yeah. And my voice clear?
Yes.
Yeah. Thank you very much for giving me this opportunity to moderate a session on L-trombopag advances based on the L-trombopag evidence-based management. I'm going to talk about a case what we have seen, and what are the day-to-day problems we face when we are using L-Thrombopag. So I'm going to start with the investigations. These are our panelists. Sir has already introduced. This is a 26 years female. She's symptomatic since 5 days. Came with fever for 1 day and then fever subsided and had a petechiae ecchymosis, gum bleeding and menorrhagia for the 10 days and complaints of fatigue and weakness. And the hemoglobin was around 8 grams and total count was 5,000. Total count is 5,000 again. Because she had fever, then we did a malaria, dengue. These investigations were done and even triple H like HIV, HBCG, HCV done and CRP was less. Bone marrow, we do routinely bone marrow for our patients. So bone marrow showed the normal marrow with increased megakaryocyte consistent with the immune thrombocytopenia. The diagnosis we have considered is immune thrombocytopenia. So the question we asked, because we use L-Thrombopag nowadays, this reproductive age group. So is there any other investigation you would like to, sir, Ganju sir?
Yes.
Any other investigations you would like to do in this patient of reproductive age group?
Thank you, madam. Yeah, most important thing which has been missed in this is the peripheral smear, which needs to be done and to be confirmed that this is basically because of the peripheral destruction of platelets. So CBC has to show the normal WBC pattern, and the hemoglobin which is down is because of probably iron deficiency. So it looks that she has ITP. I think we should do anti-nuclear antibody and the Coombs test in this patient because of the age at which she has presented. I think these are the two important tests which should be done in this patient right now.
Dr. Walid Ganima, do you do the lupus anticoagulant of the ACLA or antibiotic glycoprotein in patients of immune thrombocytopenia routinely in a reproductive age group or in a patient because we're going to start a TPO in the future? So do you routinely advise these investigations?
Was lupus and what other antibody?
Anticardiolipin.
Yeah, okay. So the antiphospholipid antibodies in general. I mean, right now I'm in Stockholm and we had a 2-day meeting, a Nordic alignment meeting, what we called it, with experts from all the Nordic countries. So we discussed, among other things, the diagnosis and the issues. That was one of the questions that were discussed. I mean, the consequences we don't know. I perform it because I think with the registries we have, if we have a complete data, then we at the end will manage to find out what are the important of or the significance of these and if there's any association or predictive values. Now we know that antiphospholipid antibodies are positive in around 1/3 of the patient, if not half of the ITP patient. So if we're not going to give TPO to all these patients, then half of the patient will not receive TPO. We know also that patients having antiphospholipid antibodies, they have higher risk of thrombosis in ITP. But once again, it is not recommended to be performed according to the guidelines routinely, and we don't know what are the consequences of a positive test. But if you have a triple positive, then you don't want to put the patient on TPO. That's what we reached to with that discussion today.
Yeah, thank you, sir. Thank you for the inputs. So, Dr. Abhijit, actually, how will you treat this patient? This is a newly diagnosed 26 years female having a menorrhagia and platelet count of 5,000. How will you treat this patient?
Yeah, so ma'am, the upfront line will be the first line. I definitely go for the corticosteroid. But meanwhile, as Dr. Ganju has advised, we do the ANA and ANA blot. And if something is autoimmune markers are positive, then upfront we'll start the second line, either like Azavan or Mycep, because definitely such a kind of patient require the second line therapy. And as we don't want to use steroid for long term, so upfront we'll start steroid plus some kind of immunomodulations.
Okay. So do anybody does the same thing, like you do ANA blot and then depending on that, do you start immunosuppressant the steroids? Any of the panelists do the same thing?
Yeah, we do the same thing. We do, madam, anti-nuclear antibody. If it is positive, then we'll go further and look in whether the patient has SLE or not, or mixed connective tissue disorder. So once we label them as collagen vascular, then I think we need to treat them also with immunosuppressant.
Okay. Dr. Walid Ganima, do you do the same thing or anything different? If patient has got ANA positive, no symptoms of connective tissue disorder, do you start a second immunosuppressant along with the steroids?
I don't do that, no. So a patient has no other symptom or no SLE, nothing indicating, just ANA positivity. That is the question?
Yes, yes.
Just steroids, and I follow, if that is the case, I follow the, just treat the patient as ITP. And maybe that patient will develop chronic, more chance to develop chronic disease. There's some indications, but otherwise, no. That's in my practice.
Yeah, thank you, thank you. So this is the guidelines. Steroids, usually we use prednisolone in our patient, in our clinical practice. And the next question, actually, we always think of patients, not in this patient exactly, but any patient you consider L-thrombang in a newly diagnosed patient. And which are the patients actually? Dr. Lalit had some emergency, could not attend. But if you can have Dr. Mallikarjun, what's your actually thought on this?
Good evening, ma'am. Thank you. So we don't routinely use TPO agonists in the upfront treatment of ITP, certainly, but then there are some patients wherein we would like to have response sooner and have some certainty of response. Somebody has ICH, somebody needs to get to a procedure urgently. So in such individuals, we make an exception. Otherwise, we typically start with first-line steroids, and typically we prefer dexapels as against prednisolone.
Yeah. Dr. Walid Ganima, you do use upfront L-thrombang in any of your patients actually, or a comorbidities, elderly patient, do you use it?
Only if the patient is like bleeding, severe bleeding, I want to achieve, but I use it at the same time simultaneously with the steroid. Have started with TPO right up front in that type of patients, and or probably patients pre-operatively or something like that, I give steroids. TPO for a transient period. If like a patient, the platelet count of 30 and I'm going to be operated, it's easier to put the patient on TPO, operate the patient, and taper after. And bleeding, of course, is an indication. In the COVID, they tended to do this, and right in the beginning of the COVID, there was a tendency to do these, using more.
Yeah. Thank you. Ganju sir, you were telling something.
Yeah, we do, madam, those patients who have life-threatening bleeding, like for somebody has been operated for prostate and now patient is having hematuria, and you want rapidity in response, then we would use steroid plus, these TPO receptor agonists. That's how we do. So any life-threatening.
Okay, yeah.
So Dr. Chandrakala, may I just ask?
Yes, madam. Yes, madam.
I'm curious that the actual time to response to TPO agonist is actually longer than it is to steroids and IVIG. So if we need an urgent response, if you want later not to give steroid for longer, that's a different thing, like you said, in elderly patient or diabetic. But in terms of rapidity in response, the minimum is about 7 to 8 days, and the median time to response is 14 days. So I do not know how it will help, but we do, technically newly diagnosed ITP, but patients who are symptomatic but have failed steroids and IVIG, we've definitely used. So they are still within the, by definition, newly diagnosed ITP, but they have actually failed the 2 frontline therapies. So, it's kind of off-label, but we have used it in that setting.
I mean, in severe bleeding, you would combine. I mean, instead of started simultaneously with the steroid, because you don't have time. You start. That's really severe bleeding we're talking about.
So TPO agonist there is not for rapid response, but rather having a backup. So in case steroids fails, you would rather not start a week later.
Every patient has an unpredictable response. We don't know. So we just try to buy time, because if we start today, then at least we'll have response later. So there are many patients who respond, they will respond more than after 7 days or 10 days. So at least in that.
Okay. Thank you. So it can be because of the elective surgeries. If posted, we can start and then we can wait elective surgeries. But emergency is also a good thing to start. Actually, that's been. So just to know, this is one of the elderly patients, more than 65 years. They have given patients with acute ITP, percent ITP. So these are the things which I thought we should consider. Maybe more than 65 years old. If they're diabetic, then we can consider this as an option of treatment. But unless it's only ITP, we have to prove, not an MDS. So that has to be kept. Always the precaution we have to keep before starting the drug for the ITP. And this is from the real world data from the US. And you can see there also the patients with less than 6 months of diagnosis also has been started, and 7 to 12 months. It's not like a chronic ITP only has been started on L-thrombopag or the TPO mimetics. So even in other countries also they're using actually in patients with acute and the persistent ITP patients. So we started on actually prednisolone and tranexamic acid. Her platelet count on day 7 was good, and usually give steroids for about 2 to 3 weeks and taper over 3 weeks. And again, after about 12 months, she comes back to us with again petechiae, gum bleeding, menorrhagia, and she was started on prednisolone by the local physician of 25 milligram. And she has severe thrombocytopenia, and also she has this petechiae, and she has got herpes actually. Now she has got this hemorrhagic type of herpes actually has come to us. And now what should we treat actually? Now, Dr. Ashok Ishram, what are the options of treatment and how should we treat her now?
Good evening, madam. Decision of treatment, particularly the second line treatment, is a patient who are unresponsive to steroid or having intolerable side effect. As Dr. Wahid told that even we can divide as per the patient choice of treatment and affordability. So if a patient is affording and willing for a long-term daily therapy, then thrombopoietin receptor agonist. If patient wants a short-time therapy, again, then we can think of in affording patient and there is no contraindication, we can use a rituximab. If patient wants if patient is not affording, financial constraints are there, then drugs like dapsone and danazole. We can also use a steroid sparing drugs like azathioprine and MMF. So if patient wants a single time therapy with high cure rate, then splenectomy can be an option. However, the durability of a response and ability to predict which patient respond and surgical complications in splenectomy are uncertain. So for this patient, I would like to use a thrombopoietin receptor agonist along with some steroid sparing agent like MMF.
Okay. Yeah, because this patient already had herpes, maybe considering a rituximab little risky, and then we might consider for actually the TPO and along with the like mycetrim, MMF, maybe a better option of treatment. Because of the infection she had, that is the only reason. So these are the second line drugs, which has been actually ASH guidelines has shown. So all the mention, you already mentioned all these drugs, but preferably we consider for the TPO along with one of the immunosuppressants. And Dr. Damodar, do you prefer to give a single agent or a combination? We already discussed, but which drugs you combine, and do you combine TPO mimetics with any other drugs in your clinical practice?
In my clinical practice, usually I will prefer with L-thrombopag along with azathioprine or mycophenolate as a combination.
Okay. Okay. So how long you continue both the drugs? Do you taper one drug first or before then actually what is your actually idea behind this, like tapering? Which drug you taper first?
I will taper first L-thrombopag once platelet count is optimum, and then gradually look for immunosuppressive in the long term.
Okay. Any other panelist has got a different actually combination to use? New patients like L-thrombopag, TPO mimetics combining with any other drugs?
Again, like Dr. Ganima suggested, low dose steroids with probably the best, efficacy, and that's really low dose. So the long-term side effects of, are fairly acceptable. So that seems to work in a significant proportion of cases. And again, what you asked, which would you taper first? So, we would generally prefer to taper the immunosuppression. But again, if the cost of L-thrombopag is a deterrent, and that threat is gone, and we are at a reasonable stable count, then the economic concerns also come in, and we may choose to taper TPO first because the patient is struggling to afford L-Trombopag. But otherwise, it's safer. So we would do it the other way around. So I think, like he's highlighted, we have to tailor make it for each patient, and there is no one regime that fits every patient.
Well said, madam. Actually, that's what, depending on the finances, we always modify it depending on the patient condition. We modify our treatment. Yeah. Thank you. And these are the combinations, sir. Actually, Dr. Ganima had already shown this combination of drugs like L-Trombopag with the steroids. Most of the combination was used steroids. DEXA is the most common combination which has been shown. It's a frontline therapy with L-Trombopag. And this is the same comment which actually Dr. Ganima had told. This small dose of steroids, actually 2.5 to 5 milligram, along with an L-Trombopag may be an option. Actually, 2.5 milligram of steroids along with L-Trombopag can be tried in one of patients who don't respond to maybe the L-Trombopag. So that's a good the thought we can take home, and then we can start our patients. So, Madam, actually, Dr. Amita, what dose of L-Trombopag you want to start in your patient? Because you're a pediatrician, that's the reason I put this. I thought I'll ask this question. What dose you start, and how do you monitor?
Under the age of 6 years, we start at 25 milligram. Above the age, it is same as the adult dose, which is 50 mg. And we monitor weekly with the CBC and platelet count, and we do not jump to increase. We give at least 2 weeks for it to show a response, and then we will try another increment of 25 mg and give it another 2 weeks. Most patients, if they are going to respond, they will respond by 4 weeks. So, occasional patient, and if we are really struggling, we may continue and add something. But if the patient is usually not responded by 4 weeks, the chance of response really diminishes. With the liver function test, for the first month, I monitor at 2-week intervals. But if that, if that's okay, then monthly. And then if they're really on long term, because now that we have so much real world data, the liver does function, especially for patients who do not have underlying chronic liver disease, really seems to be not a major concern. So as monthly with the CBC, because after 4 weeks, if we've got a response, then we monitor the CBC monthly, and along with that, the liver function test also. If we get a good response, then again, because of the economic reasons, we try and taper actually much earlier, and our target count is not 1.5 lakhs. It's anything above 50,000. We are comfortable with this to stay on the same dose. So we are, maybe perhaps because of economic reasons, we start a little tapering early, and we've sometimes seen that just a very small dose is adequate to keep our patients going. Other side effects we've not really seen much.
Okay, thank you. So actually, as Madam told, this is the dose recommendation as per the drug insert for the L-Trombopag, and how to take actually was the drug in pediatric patients and in adults. But now we heard that actually only the milk products has to be avoided, but we still follow this fasting actually for these patients. We advise them to take this drug in a fasting status, but we should avoid the milk and milk products. And this is how you increase the dose. And we started our patient on L-Trombopag and MMF and Dapsone also along with. Our idea is because of the cost, actually, by the patient response, we can taper L-Trombopag. That is the idea we use in our patients. And Dr. Mallikarjun, what are the side effects of L-Trombopag, and how do you monitor for the side effects? And have you seen any thrombosis on TPO mimetics in your clinical practice?
Thank you again, madam. So we have been using it for a very long time now, and largely very well tolerated. Most of the patients, most common things that patients come back and tell us at least initial few days is aches and pains, headache. We have seen transient transaminitis. We have seen patients having vascular events, not very common though, but we have had patients who had cortical vein thrombosis, patients who have had abdominal vessel thrombosis. Rare, but yes, we have seen them. And in terms of monitoring, when we start initially, we would want to look at the robustness of the response and rapidity of the response. We typically do CBC, SGBT, bilirubin perhaps once in 1 to 2 weeks initially. And then based on the stabilization, and once we know that the patient is tolerating fairly well, the patient's counts have stabilized to more than 30 to 40,000, we kind of minimize the dose and see them once in 4 to 6 weeks.
Yeah. does anyone monitor for the other side effects like the thrombosis, like reticular fibrosis? Does anybody do that peripheral smear? Because they're supposed to, actually, peripheral smear doesn't show the reticulin, like a leukocytes picture, the teardrop cells are not seen. It's only the marrow we need to do for the fibrosis. Dr. Amita, being a pediatrician, what about your cataract? Actually, in pediatric patients, actually, the increased incidence of cataract.
The cataract issue has been evaluated very well. In fact, it is one of the few drugs that has been evaluated well in pediatrics because ITP is so much of a pediatric problem. So the PETIT studies, the incidence of cataract was very, very low. And all of those patients had received considerable, very small proportion, but they had received considerable doses of cataract. So our current belief is we do monitor. So we have very few patients who will take it for years and years. But if they are, for some patients who are on long term, we do get an ophthalmic evaluation annually at least. But most of them, the cataracts is ascribed to the high doses of steroids or prolonged steroids that these patients had taken in that era, when they had difficult ITP. So currently that does not seem to be a major concern, but we have to watch this space and see how.
Yeah, even the literature says cataract, actually the issue has been sorted out actually. So it's now increase in the cataracts is seen, but the reports, there are studies has shown, the initial studies has shown increase in cataract. So that has to be kept in mind. If the patient has got any symptoms, we have to look into that. That's the only thing. And these are the adverse effects which has been reported in the extent study. And the same thing I told about cataracts, deep venous thrombosis, and the thrombosis incidence actually around about 2.9 to about 4%. Even in thromboplastine and the L-thrombopag, it's the same as per the literature. And Dr. Nitin, when do you reduce the dose of L-thrombopag, and how do you decide, how do you reduce the dose? Dr. Nitin Gupta?
Hi, Chandrikala. Am I audible?
Hi. Yes, Dr. Nitin.
Okay,
yeah.
Thank you. So thank you, Dr. Agarwal, Dr. Chandrikala, for having me here. And good evening to all. Again, the question here is how do we reduce the dose of L-thrombopag? Again, so we will try to reduce the dose of L-thrombopag in the responding patients. So in my practice, as per the label says that if you go reach more than 2 lakhs, then you try to reduce the dose. But most of the time it happens if patient is even 1.5 lakh also, I do reduce the dose from 50 milligram to 25 milligram. And even on that, if the patient remains stable, platelet doesn't fall too much, I do not aim for a normal platelet count, as we all do. We try to maintain a hemostatic platelet count, and which is in the almost all cases more than 50,000. So there is a fall in expected fall in platelet count with tapering the dose of L-thrombopag. We all know that, and but there may be a few patients who can maintain a normal platelet count even after withdrawal of L-thrombopag. And again, going back to your previous questions, most of the time we are also using azathioprine or mycophenolate as a combination therapy. And I am happy to state that recently we, in this ISTH Congress, which will be held in London this year, we sent a paper of our experience of combination therapy in persistent ITP patient, and that has been accepted as a poster. Again, so our experience is that it responds well. And because of the economic issues, as well as the thing that we know L-thrombopag is not going to maintain the patient in sustained remission, we try to remove the L-thrombopag first, and we try to continue with the azathioprine. Again, that is mostly for the difficult ITP patients, mostly the persistent ITP patients or refractory to steroid or any other therapy. I think that is from my side.
Yeah, thank you, Dr. Nitin. So this is the recommendation. The drug literature mentions about more than 2 lakhs, but we usually don't wait for such accounts. Usually when telecount is more than 1 lakh, we try to reduce the dose of L-thrombopag, actually, depending on the need of the patient. If somebody has got antiplatelet drugs, then we maintain a little higher platelet count, but somebody is not, actually 50,000 maybe our cutoff we use to maintain we don't aim for the normal platelet count. So the other thing is like hepatic impairment. If the patient has got, we might have to reduce the dose. So that is one thing. And renal impairment, there is no need for dose adjustment. And So Dr. Sandeep Nimani is not there. And I'll ask again, Ganju sir, do you stop Eltrombopag either transiently or permanently discontinue the drug and you still maintain the remission? Something like a treatment-free remission we see in CML patients.
Yeah. We did try sometimes to stop, because especially when patient develops some hepatobiliary problems or has thrombosis, that time we stop it. And we have seen most of these patients will have their platelet, they won't go less than 50,000, they will say more than 50,000. And in these situations, the other drugs which are already there, like immunosuppressants, the azathioprine, etc., that we continue. And most of these patients, they do well without Eltrombopag. Those patients who develop these complications.
Yeah. Okay. And Amita madam, when do you stopping or plan to stop the drug actually Eltrombopag in your patients?
So generally speaking, I mean, because children are not frequently symptomatic, and whether persistent or chronic ITP, they tolerate thrombocytopenia very well, unlike the elderly or even the adult population. So we would start this drug only in the minority of patients who are actually significantly symptomatic, or like older teenagers who need to, have an athletic lifestyle and would like to continue to do that. So we would really taper it very gradually. And sometimes we are even using like one tab, 25 mg twice a week or something before we discontinue. And like Dr. Ganju said, a fair proportion of them will actually achieve, remission, or at least a platelet count, not remission technically, but a platelet count which keeps them symptom free. But that is that the natural history of chronic ITP in children is different, because 25 to 50%, regardless of any treatment, will achieve complete remission in 2 to 5 years time. So we do discontinue or attempt to discontinue. And also when if it comes, the platelet count then goes down back to 10-20,000 and symptoms recur, we don't necessarily start at the the normal dose. We may just start with a much lower dose, because and that usually seems to work. And we may do this 2-3 times before trying to stop it completely.
Thank you. So this is the dose adjustment and when do you stop it. And but this is again from the David Kuttner, the review article. It shows actually when the platelet count is more than 4 lakhs, what is the drug insert mentions, the product literature mentions you should stop the drug. He has mentioned that actually because the rebound thrombocytopenia, they usually don't suddenly stop the drug. I will ask all of you, actually, the platelet count reaches more than 4 lakhs. Do you suddenly stop it, abruptly stop actually, or do you taper the dose? So any of you actually, Dr. Abhijit, Dr. Damodar, Dr. Nitin?
Dr. Chandrakala, if the platelet count rises more than 4 lakh, my practice is to stop, to hold for a week and follow weekly platelet count, because it is going to fall again. And we have seen some sharp fall in platelet count, but again, that can be easily managed most of the time.
Okay. So yeah, this is actually treatment-free actually remission, like without Eltrombopag, the patient has maintained the platelet count actually for about 9 months of the drug, but it's all patients of they're on Eltrombopag varying from about 6 months. So we can try stopping the drug. The patients will maintain the remission even after stopping the drug. And either because of the side effects, you can see the extent trial. Actually, the patients, about 14% patients had to withdraw the drug because of the adverse effects. It's not everybody will carry on the drug, but it's about 10 to 15% of the people have to discontinue because of the adverse events. So Dr. Abhijit is there. Dr. Abhijit, Dr. Subhaprakash is not there. Which TPO mimetic you prefer and why?
Yeah, so actually I prefer this oral Eltrombopag, because the problem with the romiplostin, the titration will be quite difficult. Eltrombopag, we can adjust the doses, we can taper, we can make alternate day scheduling. With Romi, the wastage of the doses and the fixed combination of 250 or 500, that's quite difficult. I prefer the
125 also. You have 125 also now.
Yeah, we have 125.
Yeah. So that is because the dose adjustment is good. That's the reason you prefer Eltrombopag.
Yeah, it's once a week schedule. So the fluctuation of the platelet comes little higher with the Romi compared to Eltrombopag.
Okay, okay. So does it actually, is all the panelists agree with Dr. Abhijit, or any difference of opinion? Which topomimetic you prefer in your clinical practice?
I think the family or the parents, or the patient has to really decide, because of, and now there is, initially Romi was actually cheaper than the innovator, El Trombo pack, but now with the cost being at par, now there is a real choice to the patient. So
Yes,
I think now we owe it to the patient to discuss with them.
Yes, yes. Yeah, that is actually because now there is no cost question doesn't come at all. Actually, now it's all the
They are
science.
now
Actually.
comparable.
Yeah, it's comparable. So both of them. So this is because the quality of life has seen with the Eltrombopag, because the stable platelet count and quality of been studied. It has been studied with this drug actually, and shown the quality of life is good. Even the fatigue score in the is good in our patient. So that may be one of the option you can start if the patient has got a fatigue, and we can choose the Eltrombopag. And again, actually, because of the drug has to take an empty stomach, injection has to be given in romiplostin. So those things which can be patients has to decide, and depending on the patient's condition, we can choose any of the drugs, because the response is both are same actually in both the drugs. So we have actually almost 9:30. I have one more question actually. So do you use Eltrombopag or TPO-mimetics in pregnancy? Have you used, and what's your experience in like all the panelists can respond actually. In the pregnancy patients, do you use TPO-mimetics? Start with Dr. Nitin.
So, Dr. Chandrakala, so I have used in a couple of patients romiplostim, although not kind of in the kind of very desperate situations when the patient is not responding to steroid and azathioprine, and we are left not with many options. So I think it did make some contribution, and we were able to tide through the crisis, and the pregnancy and delivery was uneventful, and there was no adverse event was noted in the newborn child. So I think romiplostim I have experience with couple of patients. Eltrombopag I have not used in pregnancy till now.
Okay. Dr. Ashok, yeah, what's your experience? Have you used in patients, IT patients of pregnancy during pregnancy?
No, ma'am, I have not.
Okay.
No, ma'am, I have not used Eltrombopag or romiplostim. So in this case discussion, actually it is I think it was used, but Eltrombopag has been assigned a category C by FDA. I don't know. There are no human studies. They only on the animal studies they found that low birth weight and some embryo toxicity. So there is no data about Eltrombopag or romiplostim in a pregnancy. So I am
There
not used
are
personally.
anecdotal case reports,
yeah.
And like Dr. Nitin said, so whatever few reports there is no adverse maternal or fetal outcome, but it is a prothrombotic state, and I think nobody would use it unless it is a desperate situation, unless there is data, and I don't think we will get data, because I don't think there will be a clinical study in this cohort.
Yes. There is a thrombopoietin which has been used. It's available in China. We don't have it, but there is a study of about 10 patients which has been published in blood, where they have seen Eltrombopag has been given, or the patient who is already on Eltrombopag has been continued actually. So there is it's not it has not shown any toxicity in the fetus or the post during the birth or the postnatal, no increase in thrombosis. But when you don't have an option of not respond to steroids, we can't give IVH to the patients, and you have to deliver the baby, and there is you have to either cesarean or normal delivery. You need to increase the platelet count. Maybe we occasionally use in the third trimester of pregnancy in our patients, because we can't use IVIG so frequently. That's the reason we use Eltrombopag. So any last comment, if any of the panelists want to share, I will end my panel discussion here. If you want to share any of the question regarding Eltrombopag or romiplostim, your experience, you can just tell.
Dr. Chandrakala, I just have a quick comment for the adult colleagues that, when they are managing pregnancy, I think if they give a clear instruction to the obstetrician to convey to the neonatologist that the baby may be born thrombocytopenic, and though it is small, but there is a risk of serious intracranial bleed. because most of the time the obstetric, because the hematologist is managing, they are just not, they sometimes ignore to give this information to the neonatologist. So that's just being a pediatrician, that's just my request. That if they can reiterate that, there can be sequelae in the baby from transient thrombocytopenia, and that can be very effectively managed because it's very transient, only in the first week or so. So that's...
Yeah. The standing order should be do the platelet count on 24 and 48 hours the baby, not the cord blood, because it may occur later actually on the day 3 and day 2 and day 3. So that should be the standing orders of all the IT patients when they are delivered. So that I think, yeah, that is good advice. Yeah, sir, I'll finish my panel discussion, sir.
Thank you so much, Professor Chandrakala, all the panelists, both the international speakers and Novartis to support us, and Yash and Kalpesh from Perfect Square for managing the show. Good night to everybody. Have a wonderful dinner. And those of you who are interested, welcome tomorrow at 7 p.m. Bye-bye. Good night.
Thank you, sir. Good night.
Right. Good.
Recording stopped.